Perfect. Perfect. So this is going fine. Just for your information, we have approximately 550 registrants for this meeting. We expect maybe 300 of them will join today in person, probably more. The rest of them will watch live on YouTube or later. My colleague is on the call will share the link, but I think Shaya, you guys can now bring in the rest of the participants, and I will invite Shayla to begin the conversation. So Shayla, if you just give me 1 minute, I'm going to turn this up for you to begin. Just 1 minute. I think you're ready.
Should we wait for the rest to join?
Yeah, I think Shayla, you can bring the guys in now. I think that's good. We'll do that. That's fine. So this is the 34th edition of the Ifakara Masterclasses, and this we hope is going to be the last one we have for this year, this calendar year 2021. And of course, we are looking forward to having a set of new masterclasses beginning next year. We're very, very lucky to be able to review the WHO World Malaria Report, which just came out 1 week ago. And for that reason, we're very grateful to all our speakers today. We have with us Absalam Noor and Pedro Alonso from WHO Global Malaria Program. And then we have Rick Stekete from, Rick, I'm not sure I'm pronouncing your second name correctly, but I hope so. From USAID PMI. Is that okay?
Yeah.
Perfect. And then we are lucky for the first time to have with us Jennifer Gardi from the Gates Foundation as well. And the four of them will join us today. With me are our co-hosts Corinne Karema, Shayla Ugoma, and Nana Abba. So I think at this point I'll hand this over to Shayla so we can begin. Back to you, Shayla.
Thank you, Fred Ross. Thanks to all the participants for joining us today for our 34th masterclass. We want, first of all, to give a special thanks to you for joining us 34 times. And we hope that we are going to have an excellent masterclass today. We welcome our panelists, like Fred Ross mentioned. We hope to have an exclusive information from WHO itself, from Gates, to be able to understand what is really happening in the malaria report, first-hand information. So today we'll be lucky to understand, most of us are asking ourselves questions. From 400,000 deaths to now 627 deaths. What is happening? What are we not doing right? How are we measuring this? How did we arrive at these numbers? So without further ado, I'm gonna welcome Professor Abdisalam Noor to give us an overview of what the report is all about. Please take it away, Professor.
Thank you, Sheila, Fred, Honorati. I think I need the hosting rights to share my slides.
Yes. I think you can do so.
Yeah, okay, good.
And I guess our participants are probably wondering, this is a slightly unusual way of doing the masterclasses. For the first time, we have an overview presentation, which will last for 15 minutes. Usually we do not have this, but we thought that because some of you might not have read the WHO report, it will be necessary that we have this initial overview for just 15 minutes before we begin the Q&A. Back to you, Noor.
Thank you. I'm trying to make sure you see the full presentation. I might have to disconnect from my multiple screens to this single one, so bear with me for a second. Thank you. Can you see my screen?
Yes.
Sir.
Thank you. Thank you very much. It's my pleasure to present to you a quick summary of the results from the World Malaria Report 2021, as was shown on the slide that Fredros had just presented. It's not the first World Malaria Report. In fact, it's probably the 12th World Malaria Report. And perhaps an interesting thing that many people do not know is that the World Malaria Report was actually first preceded by the African Malaria Report. It was the first malaria report that had a regional flavor to it, and then it was subsequently evolved into the World Malaria Report, I think, as of 2005. So typically in the World Malaria Reports, we cover a number of things, focusing mainly on interventions and their coverage, focusing on financing, focusing on the burden of disease, and the biological threats. In this year's World Malaria Report, we had a special focus on the consequences of the disruptions during the COVID-19 pandemic, as well as some of the issues related to the methodological changes when it comes to the quantification of malaria mortality. I'll take you through some of the key messages very, very quickly. The first message is that on the one hand, countries have put in a really impressive effort to avert what was going to be a really bad scenario of nearly doubling of the malaria cases. Despite all of that, there have been some disruptions, most of them moderate, and that has led to what we think is still a considerable increase in malaria cases and deaths, additional 14 million cases between 2019 and 2020, an additional 47,000 cases that are attributed to disruptions during the COVID-19 pandemic. And I use the phrase during the COVID-19 pandemic because it's not just the pandemic that's been happening. There are a few other things that will have caused disruptions, particularly in the sub-Saharan African region. And in April 2020, at the beginning of the pandemic, or in the first quarter of the pandemic, we had already released this report with the partners, anticipating a worst-case scenario of doubling of malaria deaths if severe disruptions occurred. Overall, in sub-Saharan Africa, overall, the World Malaria Report estimates a 12% increase, which is, on the one hand, good news. On the other hand, a considerable increase, particularly when it comes to lives lost. So what kind of disruptions have we seen? There have been disruptions in prevention, particularly ITNs, which is the backbone of vector control, particularly in sub-Saharan Africa. Although quite a number of countries completed their campaigns, they did so with delays. There are some that had spillovers to 2020, but overall about 3/4 of the bed were distributed. There are two things, despite these impressive achievements, there are two things to look at. The first is the delays within the schedule year of distribution, which were considerable in some countries. The second thing is that some of the spillovers have happened in high burden countries, which also has consequences for the burden estimation. On the clinical services side, a very difficult thing to measure. We have several metrics in the report. What we show here is a qualitative survey done by the WHO, which overall shows moderate disruptions across different rounds of the surveys. Second message is related to the changes in the method for estimating malaria mortality. And in particular, the method that affects the way we compute cause of death fraction for 32 sub-Saharan African countries that account for over 90%, about 93% of malaria deaths in the current World Malaria Report. So how do we actually usually estimate malaria mortality? We have three main approaches. One is for countries with strong vital registration systems, as civil and vital registration systems, as well as surveillance systems, we just accept the data as is reported. These are typically countries with very little malaria and account for a very, very small proportion of overall malaria mortality. Then there are a few countries, Southern African countries, and outside Africa, where we use the routine data. We make adjustments on the routine data to quantify malaria cases. We apply a parasite species-specific case fatality rate, and then we estimate deaths in those countries. Those account for about 7%. The vast majority of deaths, of course, occur in sub-Saharan Africa, and the method that's used there is one that builds on all cause under 5 mortality, applies a cause of death fraction. You get an under 5 mortality numbers, and then you apply an over 5 correction or fraction, and then essentially you get your total malaria. And that's the method that has been effective. Typically, the way the cause of death fraction is quantified is you start with the under 5 envelope, and then you use various data sources and various approaches depending on context. But the most important one is the one that is circled there, which essentially talks about the sub-Saharan African approach, which is essentially the use of verbal autopsies. So before even we go into many other things, many of you who are familiar with verbal autopsies would know that they have not really good specificity when it comes to malaria mortality estimation. But nonetheless, a new method and this new method essentially builds on the old one. It updates the cause of death data, whether this is from verbal autopsies or surveillance systems, and the covariate data. It's moved from a frequentist kind of standard approach to a Bayesian framework, which has a number of advantages, including a possibility of accounting in a much more effective way unreported causes in verbal autopsy studies, and a systematic selection of covariates. And then the current series has included mortality in children due to tuberculosis. So on the left-hand side is the old cause of death fractions. And you can see malaria was around 5%, about 4.8%, and we didn't have tuberculosis there. On the right-hand side is the new one, about 7.8%, a nearly 40% shift in cause of death fraction due to malaria among under 5s for the latest year, comparable year. And so this has a significant influence on the estimation of malaria mortality across the entire time series. And when you add that, the adjustment due to disruption during COVID, not only do you see a higher level point estimate across the time series, but also an increase between 2019 and 2020. So when Sheila opened this session and said from 400 to 600, it wasn't that we've had 200,000 additional deaths between 2019 and 2020. It just means that overall, throughout the entire time series, we may have been underestimating malaria mortality. And now instead of talking overall about 400,000 deaths, we're talking about 600,000+ deaths. So it's important to highlight that we did not have an additional 200,000 deaths between the last 2 years, but that there has been an underestimation across the time series, which means that we have over 600,000 malaria deaths. Cases, about 241 million cases in 2020, most of this in sub-Saharan Africa. The trend line might be depressing if you simply look at the absolute numbers, but that doesn't account for the near doubling of population in sub-Saharan Africa. And the trend is generally similar to what we usually report in incidence, except for the jump in the last 2 years. Mortality, despite the increase in the point estimate across the time series, we actually have a generally similar trend to previous years. And the change you see between 2019 and 2020 is due to the pandemic. This is what the mortality rate looks like. Overall, what this means is that on the one hand, the higher point estimate and the higher starting point of the mortality estimation means that overall we estimate we've averted more malaria deaths than we previously thought, about 10.6 million deaths, and about 1.7 billion cases, most of these occurring in the sub-Saharan African region, still a significant gain. So you would have seen the 2017 report. Even before COVID happened, we were having challenges with the progress, particularly in sub-Saharan Africa. And this report highlighted the stalling of progress, which was followed subsequently by the establishment of the high value to high impact response, and described in the 2018 report. But this is what the GTS trend lines look like. GTS, for those who do not know, is Global Technical Strategy, and the target for reduction of mobility incidents and mortality incidents was 40% from a baseline of 2015. We are not where we ought to be, which is the green line, around 35 cases per 100,000. We are at 59, so we are about 40% off track. The same trends for mortality. We ought to be at around 9, we are around 15, about 42% off track. Despite all of this, there's significant progress, particularly in the low transmission settings, and China and El Salvador were certified. However, the countries with the highest burden are still struggling, as you can see from this map, which the brown colors either suggest no change or increases of mobility or case incidents from a baseline of 2015. And you can see that there has been a number of countries, particularly Sub-Saharan Africa and the Americas, where there hasn't been much of a change. In fact, there's been an estimated increase in quite a number of them. On mortality, it's slightly even more worrying. Despite the overall higher kind of rate of reduction in mortality compared to mobility, we have had about 24 countries showing increases compared to a baseline of 2015, and most of those are in Africa and the Americas. On the elimination side, more than half of the countries have less than 10,000 cases, and half of those have actually less than 10 cases. So there are quite a lot of countries that are close to malaria elimination. In the GMS, which has received quite a lot of investment, in part to mitigate the spread of artemisinin resistance, a significant progress as well. In the highest burden countries, not so much. In fact, they account for nearly 70% of the increases you see overall globally. On progress around intervention, I'm just quickly going through the levels of intervention. SMC, in fact, an additional 11 million children protected. IPTP, a bit of a reduction during the pandemic. Airlines, most of the indicators much better than we were in 2015 or 2000, 2010. However, there have been reductions since 2017. And particularly in Sub-Saharan Africa, the situation is beginning to even be more concerning, in part because of the other threats. In addition to the pandemic, the stalling of the progress, we have the invasive species, HRP2 deletions, potential emergence of artemisinin resistance. So we are urging a much bigger focus on this region. If you look at things that have happened outside of the pandemic, you see that significant humanitarian emergencies in this region, as well as biological threats. And the final message is around funding. Well, actually, before I go into funding, just a quick note on the RTSS vaccine. We'll discuss more in detail later, which has now been recommended by WHO for widespread use in areas of moderate and high transmission falciparum settings. On financing, on the one hand, good news that it hasn't gone down significantly, or it hasn't gone down at all, fairly stable since 2010. On the other hand, it's against a background of increasing population at risk, as well as increasing cost of commodities. The GTS estimated for us to be on target, we needed about $7 billion invested in 2020. We're about $3.3 billion. And so we're significantly way off the required target for resource investment. I'll stop there. Apologies if I have taken more than I was allotted. Just urging everyone to look at the briefing notes if you want more information, but most importantly, download the World Malaria Report app, which is just more than the data, it also has all the WHO policies. Thank you.
Thank you very, very much, Noor. If you can stop sharing the slides.
Can I stop sharing?
Yeah. So this was a great overview by Noor. Thank you so much for providing this. And I believe that all our colleagues on the line who had not had a chance to read the report will find this as useful as we found it. Before we continue, it would be nice. I would like to hear from all our other speakers what their overall view is regarding the messages that Professor Noor just provided. And I think the right place to begin here really is with Dr. Pedro. Just for 1 minute, what is, you think, the main take-home message from both the report itself, but also the presentation by Professor Noor? And then after Pedro, it would be nice to hear from Jennifer, and then from Richard as well. Back to you.
All right. Well, Fedros, thanks. I mean, that's a challenge for anyone, and certainly for me, to summarize in 1 minute what is effectively a very large piece of work with a lot of information, with a lot of potential implications. So now you're forcing me to focus on just a couple of messages. Number one, the countries have done well to avert the worst consequences of COVID-19. So that's a positive message of congratulations, even if there has been an extra 47,000 deaths and 12 million cases associated with the COVID-19 associated disruption. So it could have been a lot worse, but it's not great. Number one. Number two, I'm sure many of us on this meeting felt that way quite some time back. And the recalibration, the reassessment of the contribution of malaria to under 5 mortality is probably giving us more of a precise picture of what the real burden of malaria is. And therefore, I think the second message is we were probably or surely underestimating it. In that regard, we're not surprised that the new estimate is higher. And if I may be slightly provocative, I think we're probably still underestimating the real malaria burden, as it is not taking into consideration indirect effects of, or the so-called indirect malaria mortality. So message number two, we have a more precise estimate, and the implication is we have a bigger problem to deal with than what we previously thought. And message number three, which is, I think, the really worrying one, is we see no signs of change. We've been calling out since 2017 that we were stalling. There is a substantial number of countries that have made no progress or have actually gone backwards with regards to a 2015 baseline. Therefore, it's not COVID related. This is way before. And frankly speaking, I don't see substantial changes in the way the malaria community behaves and acts in response to this hard data that we're making no further progress. And therefore, I think we have a malaria crisis. We have to choose our words carefully, but I think we have a very serious problem, and that we're not moving in the right direction. Whether we want to call it a crisis, whether we want to call it whatever, but I don't think it has sunk sufficiently in the minds of the malaria community that we need to do something drastically different, and that just doing the same thing over and over again, which is what we've been doing over the last few years, is not going to get us anywhere. I often challenge people, you know, Noor could already write the 2030 report, and he would get it right if we just go on behaving as we've been behaving over the last 4 years. And that is just doing the same thing over and over again.
Pedro, this is very, I don't know exactly how to respond to this, but, you know, on planet Earth, you in particular, maybe I'm right or maybe I'm wrong, but on this planet of ours, you probably bear the biggest responsibility of informing people what the true status of malaria situation is. And so it is a little, to some extent, sad, to some extent, very painful, but also, a point of reflection, really, when you tell us so openly that we have a malaria crisis. And I know that your job is very difficult. I feel for you. I don't know how it feels to be in that position. Very briefly, before we go to Jennifer and Rick, how would you like to see the responders behave?
We don't have a magic formula, but I would like to see a much more open to change mentality, more of a problem-solving mentality, that we're not, less of a resistance to anything that implies any change. Let me just recall that when, in response to the 2017 World Malaria Report, when for the first time we called out that there was a problem, and we brought forward, with support from external trusted colleagues, and I see Larry Slutzker is on the call and others, the concept of the High Burden, High Impact Initiative and the use of data to inform stratification and subsequent subnational tailoring of, there was massive resistance within WHO and within most of the external partners, interestingly, not from the countries themselves. And it's because the malaria community is locked in, this is how we always do things. We just have to quantify how many bed nets this country wants or needs, and how many ACTs and how many RDTs, which is important. But just going on doing that in the same way is not going to get us anywhere. So it's a mindset problem. We need to show greater flexibility, be smarter at understanding that we're facing a really complex problem, and that, just as the old classics, Nájera used to say, malaria is a problem to be solved, not simply a task to be performed. And unless we take that on, we won't move.
Thank you. Jennifer, we have a malaria crisis. What's your take?
What's my take? Oh, gosh, Pedro's a tough act to follow, because his points and the solutions that he proposes in that last comment, I think, are incredibly important. So I think what I would choose to underline is, a big takeaway for me out of this report is that point that we are sort of finding ourselves at an inflection point. When you think about malaria eradication, it really is a marathon. It isn't a sprint. And if anybody out there has run a marathon or knows people who do, I do not run marathons, but I'm very familiar with the concept of marathoners reporting hitting a wall, something that's usually about mile 18, 20, around this 26-mile journey. And that's where we are now. When it comes to declining incidence and declining burden of malaria, we really have hit that metaphorical wall. And so if you were to talk to a marathon runner and say, well, okay, what do you do when you get to that point? They really look at that as a time to mentally reset, to tap into new reserves of energy, to try something different techniques, different motivations. Really hitting that wall is a cue that change is necessary. And so for me, this year's World Malaria Report really sort of underscores that we're at that wall. It is time to do something different. And I think what's nice about the report as well, I'm an eternally optimistic. I do love to find hope in every document and report that I read, and I think there is some hope in there. You have seen 12 countries eliminating over the last 20 years. You had El Salvador and China who managed to get elimination certification during a pandemic, which is incredibly commendable. And the Southeast Asia region was able to hit their GTS targets even in the face of mounting drug resistance pressure. So there are signals that we can can do this. And I think one of the other bits of hope that I find in that report is that it does lay out a lot of the things that describe the path that will help get us past that wall. In particular, I'm thinking of things like the High Burden, High Impact Initiative, like taking that subnationally tailored approach to malaria planning, like increased domestic funding and attention, as well as global attention and funding to the problem, and really having a toolbox of innovative and transformative tools in the pipeline, but at the same time being able to scale up the coverage of the tools that we have now. So for me, that has been the biggest takeaway from the report, that the pandemic has given us an opportunity to change. It's sort of created an inflection point. I think we as a community know what it is going to take, as Pedro just articulated, to get to eradication. It's just the time to step up and act is now, and hopefully catalyze some of the momentum that is coming out of the COVID-19 response. Another good news story in the report was really the malaria community coming together to buffer against some of those severe disruptions that in 2020 we were concerned, could set us back with like a doubling of malaria deaths. So tapping into that energy that we can respond to an emergency like COVID. Malaria is just as much an emergency. I think there's reason to be hope, but it is going to take a lot of hard work to bust through that wall and get to that marathon finish line.
Thank you so much, Jenny, for this. It's I'll have to listen to this many times with my colleagues afterwards just to get that. Rick, Jennifer, just like Pedro, Jennifer's telling us we've hit a wall. We are at an inflection point. We need to really think. Rick, it would be nice to hear your overall opinion about this, but also whether you think that change will come from inside, or whether we must now look from outside the malaria community. Rick, back to you, please.
Yeah, thanks for that, Fredros. And well, if it was hard for Jennifer to follow Pedro, it's hard for me to follow the two of them. I do, I agree with what both of them said, and maybe just to add a couple of points. One is that, first of all, it's remarkable that we have the quality of the report that we have. So I just want to, tip my hat to colleagues at WHO for the hard work. It's not just 1 year that we've got this. It's been progressively clearer, and if folks have been following the World Malaria reports over time, that quality and in this case the information on new numbers is just seeking that, and unfortunately we're still estimating because we don't count very well. So just to call out one issue is, in terms of the tools that we have, one of them is our information system. And that's a tool that does have some backing. It's certainly not backed just by the malaria community. So when you ask, do we need help from others? Absolutely. And I'll call out the information system. And just to respond to that further, you mentioned the others. And indeed, I think we haven't been bad about engaging others, that is antenatal clinics and their ability to provide prevention for pregnant women directly, their ability to provide insecticide-treated nets for those households, EPI programs. All of a sudden with a new vaccine, we're not just asking help from EPI, we're depending upon them going forward with a new vaccine. I do think, this report is always a combination of good news and bad news. Let me pick on the good news. So, right now we've listed 85 countries that are malaria endemic. It wasn't all that long ago that the number was over 100, and so we should be pleased with that. As Noor pointed out, it's about 55% of those countries have less than 10,000 cases reported, and those are actually reporting cases. So they're down to very few numbers, and they're headed towards elimination. And that's an impressive opportunity. The downside of that is that if you live in sub-Saharan Africa, you're not one of those countries. And we've talked about this for a long time, that, you know, this is a disease of Africa. Well, if any report ever showed us that this is really, really a disease of Africa, and that's something to step up and take stock of. And where do we find the external support, not from other programs, not from antenatal clinic programs and EPI programs, but leadership on the continent? We talk about this a lot. We don't have our act together really in terms of what that conversation is at all levels within the countries. But I think that this is a critical issue going forward. And, you know, whether it's the 6 countries that have more than 50% of all of the cases, or I believe it's 26 countries that have about 90+% of the cases, it's down to, you know, having that dialogue country by country in these hardest places and trying to figure out what to do. Because, you know, we've got a new intervention with a vaccine coming on board. That's not just new, that's a completely new biologic modality that helps us protect people from malaria. And it's different from addressing the vector, and it's different from addressing the existing infections in the humans. And so this is really an important opportunity. And if we don't get that right in the high burden countries, the world will look at us as not having our act together. Maybe I'll stop there, I think, but again, just kudos to the team that put the report together. I know how hard this is. We're from PMI's perspective, where I sit, we're very happy to have contributed what we could, and to have the dialogue that goes into this, and happy to be here today. Thanks.
Yeah, thank you, Rick. And as well presented by Noor, this year WHO applied a new statistical method to calculate the number of malaria deaths. And if I recall well, and you can see that in 2018, there was a meeting report of the WHO Evidence Review Group on malaria burden estimation method. And we are really lucky and happy that Rick, who was the co-chair, is here with us, and Professor Binka. And if we read well, the meeting recommended improvement of the metrics that were used to estimate the malaria burden, as well as the assumption and method for malaria mortality. However, this was not done at that time, although it was needed for immediate action. And interestingly, the meeting noted that most of the recommendations from that meeting were also suggested in 2012. So this year, WHO is using a new methodology, of course, revealing higher number of estimated deaths. Pedro or Noor, can you explain us why the change today? And I mean, why it was not done before, why today, and what is the key message?
So I'm very happy to take the easy questions, and thus I'll pass this one on to Noor.
Thanks, Corinne. First of all, you are right that the evidence review group meeting that was held in 2018, which we co-chaired, and preceding that was another 2012 one, had somewhat similar recommendations, with a much more expanded list of recommendations in the 2018 report. Sorry, I seem to have been talking to myself. Thanking Corinne for raising some of these critical issues.
Noor, I'm not sure if it's on your side, but
the sound is poor.
There's a little
can you
sound
repeat,
problem
please?
from your end.
Yeah, sorry.
Is it still a problem, my sound?
Yeah, a little bit.
I don't know what the problem is.
So I'm sorry, Pedro should take that then. Sorry, Pedro.
Thank you very much for putting me in the spot. I'm sure he's done it on purpose. But Noor, you better find a better place where you can be heard. No, Corinne, you're right. We've been concerned as to ways in which we can clarify how we produce the numbers and identify areas for potential improvement and then implement them. And just to be clear, we haven't done extremely well in that space. And all I can say is we have not had the bandwidth to take some of those recommendations forward. Rick alluded to the fact that we're not very good at counting, and he's absolutely right. I mean, for countries in which they count and they have the surveillance system, there is no discussion as to what the malaria burden is. The problem is that in countries in which we can actually estimate, or we have measures, we have indicators on the strength or not, or otherwise, of their surveillance system, then we need to rely on models. And that's an uncomfortable situation to be in. These are models that rely on the prevalence to incidence transformation, starting from the prevalence data, often provided with the help of PMI through malaria MIS surveys. And therefore, we're making estimates for the number of cases. The number of deaths, which is what has really changed this year, comes out from a group that sits somewhere else in WHO, in which they define, mostly relying on verbal autopsy techniques, which makes us also feel very uncomfortable, what the relative contribution of different causes of death to the under 5 mortality envelope. And it happens to have been this year, and that we only found out as a malaria department a couple of months ago that a paper was coming out in Lancet on November the 9th, in which this other group corporate of WHO had performed a recalibration of the relative contribution of under 5 mortality, and whereby malaria moved from accounting just over 4% to over 7%. There is still a prevalence covariate that comes into all of this, but that is essentially what has pushed up the mortality estimate of under 5s, while not having really modified our number of cases, because one of the things that was called out in these reports that you were alluding to, our case incidence versus our mortality are not exactly linked. And this has always been the case. And of course, in a real world, in a desirable world, they would obviously be connected. And where we can effectively count properly, that is not a problem. But for large parts of the world, particularly in sub-Saharan Africa, or many of the countries in sub-Saharan Africa, where surveillance systems are not robust, the estimates of malaria disease follow one route, which is by and large based on modeling. The estimates of mortality are based on the overall under 5 mortality and the relative contribution that this group assigns to it. I hope Noor has listened and he is not in deep disagreement with what I've said.
No, you are the boss. So thank you, Pedro. And the fact that WHO is estimated while countries are really investing in their health information system, as well as trying to improve information system. When you look at all the investments done by the global funds, PMI, the Bill and Melinda Gates Foundation. So can you tell us, or Jen, what is needed for WHO to be able to use country, and maybe what is the deadline? When will we be able to use the country data and stop using modeling estimated data, and so that country can be comfortable. Because when you are a program manager, you have your data, you give to the minister, and then of course you also see the WHO report with totally different data.
Yeah, that's a fantastic question. And I think you just hit on a really important point there, which is when you've got different sources of data, different numbers, different sort of numerical estimates floating out there, it makes it really difficult to tell a compelling story. What's been nice over the last many years is we've seen that no matter where an estimate is coming from, whether it's World Malaria Report, whether it's the Global Burden of Disease Report, when it comes to cases, the community has generally been aligned and estimates have been fairly similar to each other. But they have always differed in this mortality estimation. So I think, this is a welcome change, having a community where the mortality estimates that are coming out are more closely aligned does make it a lot easier for us as a community to tell a compelling narrative, to get program and to get donor attention. But yeah, as you said, it doesn't change the fundamental message, which is at the end of the day, we do need better data. As Rick said and Pedro repeated, we are not very good at counting. We would love to be in a place where we don't have to do this imputation at all, and can just rely on good, true, accurate data coming out of health systems. So I think that's something that we can get to in the next decade. We see the path forward, and I think this is another example of where the COVID-19 pandemic has really accelerated the opportunity for other diseases, including malaria. It really has underscored the need for and the utility of real-time, high-quality data. So what's nice to see now is the community has recognized the importance of surveillance. Surveillance is almost considered an intervention in and of itself. And with countries going on a journey to improve their surveillance systems, we know what is needed. We know that you have to go in at the beginning and really assess what the issue is. Every country collects data in different ways. Every country uses different types of data platforms. Every country has different data types feeding into a Ministry of Health, the National Malaria Control Program. So first of all, assessing, what is out there, how well is each part of that system functioning, and where are the gaps that need to be addressed. And that's something, where my team at the Gates Foundation is really interested in investing. It's helping countries to fill those gaps. And if there's a blank, if there's a blank picture in some part of a country's overall malaria surveillance system picture, how do we color that little bit of the picture in? I think in addition to improving and strengthening basic routine surveillance, whether it is getting high quality, timely, and complete data from community health workers, whether it's getting good reads on what's coming in from RDT usage out in the field. There are other novel surveillance systems that we can tap into too, and I think that's a really promising route for addressing some of those gaps going forward. I know Rick mentioned earlier ANC surveillance. This is a tremendous opportunity for malaria to tap into this other domain of maternal, neonatal, and child health and leverage visits to ANC sites for multi-disease surveillance. We can do this for malaria. We can do it for a number of other things as well. And I'm really excited about the opportunity of other tools that can give us kind of real-time readouts on what's happening. Things like genetic and genomic surveillance, both of the parasite and the mosquito vector. Right now, we're relying on malaria surveys, DHS surveys that might happen every 3, every 5 years. Oftentimes when we're trying to use models to do that imputation of case counts, of mortality counts, we're relying on data that is some years old. But with genetic and genomic surveillance, if you're able to collect samples, it could be samples collected through something like a treatment efficacy study. It could be samples collected through ANC surveillance. It could just be discarded RDTs that are being used as part of case management. But that gives us a really powerful window to look at everything from trends in drug resistance through to the population structure of parasites or mosquitoes. And the population structure of a parasite, how much genetic diversity is in the parasite population, turns out to be a pretty decent surrogate for transmission transmission intensity in a region. So I think we've got the opportunity now, having seen things like genomic surveillance used for COVID and variant tracking, to really pull those things into the malaria space. I think we've got the opportunity to do better mortality surveillance. There are programs out there like CHAMPS that are trying to tackle this issue, but I think it's going to take more than just mortality surveillance, verbal autopsy and tissue sampling in under 5s. I think we need a stronger picture of what's happening in the over 5 population as well. But at the end of the day, I should say that numbers, whether they're estimates or not, they are really powerful advocacy tools. They are something that are so integral to us being able to tell a compelling narrative, communicate the massive impact that malaria has, and communicate changes over time. So this is an area that I think we can improve in the next decade. It will take a lot of work, but we've got some novel data streams that we can pull in and a really strong use case for making surveillance a better intervention.
Thank you, Jane.
Yeah, Corinne, so there is a follow-up question before we let the methodology and data section rest. There's a question about how countries and NMCPs will reconcile their investments, the investment they're putting towards, enhancing DHIS2 data and systems, and, reconciling between this and the new methodology that has been used in the report, and also why the methodology has not been used for case data, and whether or not there are guidelines for countries on how to compare this specific data set with the previous data sets in terms of, for example, when they come to forecasting for the different commodities that they need to for malaria control. Perhaps just a comment on that.
No, can you?
Yeah, can you hear me? How is my voice?
Yes, very.
I'm not sounding like a dinosaur. Okay, good. Those are really great questions. The first thing is countries, regardless of whether we're using the current method or the previous one, have always fed back to us saying we think we are estimating more malaria deaths than they have seen in their systems, which at face value is true. And the reason for that is when you start looking at the sensitivity of the surveillance systems and the civil and vital registration systems, they actually miss out quite a lot of deaths. And the way to quantify that is to simply look at the number of under 5 all-cause deaths reported in your system and divide that by the estimate of all-cause under 5 in the country for a given year, which is a fairly robust estimate. And that fraction essentially tells you how far off you are in terms of picking up under 5 mortality, which could be a signal for all other ages, mortality in all other ages. The second thing that's important to reflect on is that for purposes of commodity quantification and thinking through the needs within the system, we encourage countries to use their own data, because there are a lot of other things that are not necessarily captured in the aggregate national estimates that is presented in the World Malaria Report. And in any case, you need to think with that data at the subnational level. So the World Malaria Report estimates isn't the right vehicle to make decisions on commodity quantification and other systemic things within a country. Finally, I don't think it's really important to necessarily compare what the old estimate was for a country versus the new estimate, because it actually gets you to no particular solution. In many ways, if you are familiar with the estimation of burden of disease, the shift that has occurred, despite the complexity it comes with in the new method, is actually better. We're using better statistical methods, we're using more updated covariate data, we're using more surveillance and verbal autopsy data, regardless of the challenges with those data points. So I'll stop there for you.
Yeah, thank you, Noor. I think that speaks to being open to new methods. Yeah, back to you, Corinne and Fred.
Yeah, I think we should move forward now. We still have a number of questions that we need to tackle, and we have a question here for Professor Pedro and Rick. This is to do with the financing and also the economic case for malaria. The eradication, shall we say, the eradication committee or the Malaria Eradication Strategic Committee, I don't remember the exact name, the WHO formulated a year back, looked a few years ago, looked at the economic case for malaria eradication. And this is also captured very well in the documents that accompany the GTS. You see a very clear return for investment, very high levels of return on investment. So it is true that even for countries that are low-income countries, classified as low-income countries, there is a lot of value in going forward for elimination. However, if you look at the data that Professor Noor presented earlier and also what is in the malaria report, this is what you see. 6.8 billion needed. We have only $3.3 billion available. Most of this coming from the countries and from the United States. Thank you very much to the people of America, from the American people. And it's great also to see just how these low-income countries are already able to raise a third of this massive bill. I think that's incredible, just given what the economies are. The question we have for Professor Noor, for Professor Pedro and Rick, do you guys have any suggestions on how the gap between 3.3 and 6.8 could be addressed? And we have seen some estimates that suggest that the 6.8 could actually be an underestimate, that the true value is probably around 10 billion. What are your suggestions on how countries should move towards that? We can start with you, Rick, and then we hear from Pedro.
Thanks, Fredros, for the easy questions. We appreciate the opportunity, and I'm sure Pedro's waiting to hear what I say so that he can temper this. You know, this is obviously really hard, and so I very much appreciate your thanks to the American people. We're not the only people on the globe, and the U.S. government is, you know, always in an interesting situation. There's very little money to go into foreign assistance in general. We have plenty of challenges domestically. Every country is pretty much facing that, particularly with COVID-19, where the costs of everything are going up. The supply systems are harder. They're getting increasingly expensive. And I think you're right that the 6.8 billion, when we go back to relook at that, that's going to be a different number, and it's not going to go down. That said, that return on investment is huge. And so people have to have the long view. I'll go back to Jen's comment about the marathon here. Running the marathon, you know, you hit a wall, but if you can break through that wall and finish it, this has got huge return. In addition to that, the race is over when you do that. You can go on to run other races against other diseases, against other problems you face. But unless we, you know, for the countries eliminating, this is huge for them to be able to, you know, keep a surveillance system that tracks any concerns of reintroduction, but not have to build a system specifically for this disease. So with that in place, how do we get that additional money to come forward? One issue is probably being good about our communication and our consistency of our messaging, and joining forces to do so. Where's the money going to come from? Well, maybe from some country governments, but let's not rely on those for doubling this available resources. So what about the countries? Everybody wants the countries to add more, but to be honest, you know, if I look in sub-Saharan Africa, they're paying the health workers, they're running the clinics, they're moving the drugs and the products to places. That's not without cost, and we've probably not been great at estimating or at counting that cost consistently. But if you look at that, I believe it's the pink bar in your graph there. That's pretty stable over time. Is there play there, or what are we counting properly? That's going to be tough, but it's a conversation with the Ministry of Finance, not with the Ministry of Health. And so I'll just say that at the country level, it's really engaging with the Ministry of Finance and the other partners that would matter. What about, I'm loath to say the private sector. People use the term private sector for a variety of different things. In one hand, you might say, well, the private sector is providing services, and that's helping as well. There are wealthy people out there who one could figure out how to get them engaged. I'll just call out, MasterCard just went together with Africa CDC with a substantial investment. Are there more opportunities for that? Because right now, malaria isn't the only pandemic out there, on the African continent in particular. And COVID-19 is messing with us seriously, as just evidenced by what Noor presented to us. So it's got to be a combination. And to be honest, we actually need a team of people who are really adept at talking to those folks, both country by country in the countries, as well as in the global community. And we have to keep the resources coming from country governments around the globe. But the blue and the brown bars here are pretty consistent. And then there's not much else going on following the Global Fund and the President's Malaria Initiative and the countries. So it's a big task to take those, what are small pieces at the top of the bar, and figure out how to add to them another group, not to mention increasing some of those that are already there. So I'll stop there. This is perhaps our hardest task right now, because maybe one last point, and that is, when you think about what's stalled, unfortunately, population growth has not stalled. It has been steady, and you can predict that for the next 30 years going out, with maybe a little bit of uncertainty, but an awful lot more certainty than anything else we have. And so what's stalled is the money has stalled. And to be honest, the flat line, given population growth, means that we've been working on efficiencies. And there are limits to how efficient you can get with a fixed set of resources. So just to call out that new resources are critical, staying efficient, showing our efficiencies is good as part of the argument for those resources. Over.
Thank you so much. Thank you so much, Eric, for highlighting that. And I mean, when I was growing up, there was no Global Fund and there was no PMI. So it's really, really nice to see them do the great work that they do. We appreciate this. Pedro, please. Anything to add from
little to add to what the wise and well-informed words of Rick. And I entirely agree with what he's saying, because effectively, given population growth, the flatlining in funding means that the per capita investment has decreased. And if we don't see a greater worsening of the situation, is because the efficiencies, which have their own set of complexities around. But when I look at and I do look at it rather regularly, the upper right-hand graph, it evokes in me a couple of questions. One, reminding ourselves what you've just mentioned, Fedros, that 15 years ago, 20 years ago, there was no funding. So this blue circle of 3.3 billion is already a massive improvement on where we were just 20 years ago. But we don't know for how long is that going to last. And therefore, looking at that figure is we've done great compared to where we were 20 years ago, but it's a fragile situation because we're not sure for how long that's going to go. The second thing that a sign of concern that this figure represents for me is that the pink line has flatlined. And therefore, the relative investment of the endemic countries themselves on malaria has not been increasing, even though most or a substantial proportion of the malaria endemic countries have been experiencing substantial economic growth over the last 15 years with some bumps, but has been experiencing. So the lack of increase in funding from the endemic countries themselves, I think, is a real matter of concern and something that we should be, as a malaria community, but more broadly as a global health community, as a public health community, should be looking into it with greater attention. Because perhaps being enormously grateful as we are at the role that the US has been playing, because don't forget that a third of all the global fund money is also US money, the lack of similar traction from Europe is a concern, and certainly the traction from outside Europe is a concern. So the domestic funding seems to me like one of those areas that we really need to pay attention to. To finish on an optimistic note, I think that in this regard, COVID-19 may offer us an opportunity. So when societies have really felt threatened in the North, there's been no limit to the money. I mean, these figures seem like peanuts, given the type of investments that have been made on COVID-19. And from a greater political lens, I think health has really been put top of the political agenda. And therefore, building on this momentum, I think it's a great opportunity to support or incentivize or work with national governments to put not just the malaria agenda high up, but the health agenda, because the malaria agenda has two components. It has the commodities, but it has the health systems. And strengthening the health systems in the endemic countries is a key component of our fight against malaria. It may not be labeled as malaria money, but it's as important as getting the commodities out there.
And I just want to jump on Pedro's point to call out that Valentina made a really great point in the chat that alludes to exactly what Pedro was just mentioning, escaping these sort of vertical disease silos. Yes, when it comes to R&D, every disease will need its own investment portfolio. But when it comes to implementation, when it comes to service delivery, there are a lot of efficiencies that we could gain within the existing funding envelope by just working better across disease verticals. This is something that is not a unique problem to malaria. I think every disease kind of exists in a silo. So the more we can figure out how do we work together on things like common delivery platforms, health system strengthenings that have these knock-on benefits across the board, in the interim, we'll be able to use that limited envelope smarter. But it certainly doesn't erase the need that we do need a massive injection in funds from global donors, from domestic programs, and from new actors in the space as well. Yes, I see your small Fred Rose agrees.
Yeah, indeed. He's 17 months and he is in the statistic gap. So when Noor comes up and says a child dies every minute, I think about him a lot. And it's important that we raise this money. Back to you, Nana.
Thank you, Pedros. And so on this slide, we can see here that there were some conflicts in the continent. And then perhaps, Pedros, you can move up to the next page. These conflicts were reported as of 2021. And then here in this slide, we can also see that there are some converging threats, biological threats like the HRP2 and 3 deletions affecting the performance of the HRP-based RDTs. We also see increasing insecticide resistance, and then the invasion of Anopheles debansii as well in the Horn of Africa. Then we also know that in the same part of Africa, there's Plasmodium vivax. So together, all of these are affecting really. And how are we going to prevent, or how are these affecting accomplishing the set of goals to fight the malaria disease? In short, really, how do we deal with the situation in the Horn of Africa? Perhaps I'll give this question to Noor.
The question on biological threats is probably best addressed by Pedro.
Pedro, over to you then.
All right. So on the biological threats, as you know, WHO has its map with all the georeference points, both insecticide resistance, drug resistance, HRP2 deletion. So I think we have a substantive problem with HRP2 deletions in the Horn of Africa. I think the good news generally here are going to be good, because we're going to have, we start having already pre-qualified tests based on the LDH enzyme that detects parasites that may have actually deleted the HRP2. So the fundamental problem of missing or not diagnosing malaria infections, which is a concern and remains a concern, but I think the overall outlook, if we do things the right way, and here the support of the Gates Foundation and the investment on improved diagnostics, it's of critical importance, and perhaps we haven't really highlighted it enough, is essential. So no time to call success yet or to call victory, but and improving our surveillance for these deletions and monitoring that is important. But I look at it with a slightly more optimistic view. Insecticide resistance continues to be a challenge, a massive challenge. I think we've now pre-qualified and formally policy recommended PBO nets, so the improved efficacy with the synergist PBO. That is not going to be the end solution. We need to look for others, and other new generation nets are being tested and evaluated, but the fight or the management of the resistance threat is going to be with us for a long time. What has really come forward, Anopheles stevensii, invading species, again, Horn of Africa, expanding substantially in a number of areas, an efficient vector in urban settings. And again, we're tracking this closely as to how it further expands. So at this point, it's a matter of surveillance and hopefully new, really innovative vector control approaches, which again, the foundation is spearheading some of that work, could be deployed. Some of the Oxitec genetically modified mosquitoes could be a solution, and these are going to start hopefully being tested soon in Djibouti and in a number of places. I guess that what is really new on the continent and a source of, I would say, major concern and a major risk is that I think we now have pretty much confirmed delayed parasite clearance with or identification of mutations on the key 13 propeller gene associated with delayed parasite clearance in 2 or at least 3 independent foci in Africa. All of these are on parasites with an African genetic background. In other words, these are not imported parasites from Southeast Asia or anywhere else. They are de novo appearances in Africa, which, by the way, is what a WHO advisory committee thought would be the most likely event 5 or 6 years ago, that the risk was probably small of importation of parasites from Southeast Asia, that the bigger risk would be de novo appearances. And I think that that's what we're seeing. I think that this is a potentially massive problem that we haven't really mapped out yet sufficiently well. We are scaling up those efforts, and we will be, I think we can already announce, within the coming months, we will launch a detailed exercise for WHO together with partners, and most importantly with countries, develop a plan to define in greater precision the problem, track it moving forward, and establish what are the key mitigation or containment strategies that need to be put in place. This is really important.
Thank you very much. Yeah.
Yeah, and so this will happen very, very soon. Again, with support from the Gates Foundation and others. This is going to be a really complex exercise because there are multiple elements to this. The fact that we only have most of the first-line treatment is based on one single antimalarial medicine, AL, is a source of concern. It therefore will affect or call upon some of the KPI indicators currently used by, say, the Global Fund and others, where we have to ensure a healthy market of alternatives that could potentially allow for rotation or mosaic approaches, which is very difficult right now because there is no market for other drug developers and producers outside AL by and large.
Yeah,
so
thank you very much, Pedro.
Corinne, before I move over to you, I just had one more question. It's very clear. Thank you very much, Pedro, for the answer, that an accelerated action is indeed needed. And here I'm throwing a question to PMI and Jennifer as well. Are there ongoing or planned funding initiatives to address these challenges that I've just exposed in the Horn of Africa?
I'm happy to jump in first and then turn it over to Rick. Yeah, this is getting ahead and staying ahead of resistance, whether it's anti-malarial resistance, whether it's HRP2/3 deletions, or if we even just extend that to include invasive species and new threats. It's really a key part of our strategy at the foundation. What we've seen in the greater Mekong subregion is that you can, with a concerted response like the one that WHO is about to lead the mounting of, you can stand up to the threat of resistance. It takes enhanced surveillance, it takes new tools. So there is a substantial activation energy to get to an effective response, but we can do it. I think one of the things I specifically want to call out here, Pedro mentioned some of the new tools that are coming down the pipeline. R&D is always going to be critical in this space, coming up with new transformative tools. But all of these threats that we've covered, anti-malarial resistance, HRP2/3 deletions, detecting Stevens eye in the Horn of Africa, these are all things that molecular work can actually assist with in a big way, whether it is looking for molecular markers associated with artemisinin resistance or resistance to other partner drugs, whether it's looking for those HRP2/3 deletions, or whether it's using genomics or even just simple PCR assays to speciate mosquitoes to understand the composition of vectors locally. It's again, one of those scenarios where molecular information can provide fairly real-time and very granular data. And what we've seen, HRP2/3 deletions have been a recognized threat around the world, but in sub-Saharan Africa for some years. And I am personally seeing a lot of country programs who are really thirsty to be doing molecular surveys for HRP2/3 deletions. So what we've been encouraging those countries that we are funding to do those surveys, we're saying do the HRP2/3 deletion work, but also tack on anti-malarial resistance surveillance as well. It's the same laboratory, the same set of general sort of biotech high-tech approaches that will get you answers to multiple questions at one time. And especially when you're able to tack that molecular surveillance onto existing activities like, for example, a treatment efficacy survey, which PMI is, one of the major funders and implementers, you can get an incredibly robust picture of what's happening in your parasite and in your vector populations as well. So it's an area we are investing really, really, really heavily in. And I think in the next few years, we're going to start to see very high quality real-time data coming in from these relatively light lift molecular programs. Doesn't take a whole genome sequencing facility. In many cases, just, a simple PCR setup can do. But happy to turn it over to Rick for more thoughts from the PMI side on these.
Thank you, Jen. Perhaps I can, Colleen, I can hand over to you.
Thank you. So as Pedro was saying, that artemisinin resistance is really, we all know that artemisinin is the core compound of actually the best available anti-malaria medicine. And we are seeing in the African region, as you can see in Rwanda and Uganda, resistance has been confirmed. So I wanted to ask to partners, Jen, Rick, as well as WHO, what are you doing to respond and to address to this threat? And do we expect to have the same investment that we had in the Mekong?
Corinne, if you don't mind, I would like to request actually that, I talked to Pedro recently, 2 weeks ago, and he told me a very interesting story about the Mekong program. And I'm wondering if we would be willing to take that story again. Deus and myself have written a little bit about this, but Pedro, is this something that you'd be willing to speak about it?
Sure.
In response to Corinne?
Sure. You'd need to remind me what on earth did I say? but
how did they respond to, how is that response going?
Yeah, no. So the world woke up to evidence initially generated by Harold Noodle in Cambodia back in whenever it was 2007, that parasites were actually deploying delayed clearance time to artemisinin, a drug that had been labeled as it's impossible to have resistance against this drug. There's a very famous professor that will remain unnamed that said in a major seminar, artemisinin resistance, never in my lifetime. Well, the truth is that it's not sensu stricto parasite resistance, it's delayed clearance. For all we know, all parasites in this world, if subject to the right amount of dose of artemisinin for the sufficiently long time, usually above 7 days, they all die. So it's delayed parasite clearance, or it's partial artemisinin resistance. The problem is that the term has often been used in an odd way. Well, the truth is that quickly expanded, and given previous experiences with triple DHFR, DHPase mutants and others, showing that there had been a spillover from Southeast Asia over to other parts of the world, the question was felt that there was a real risk to drugs, not just in Southeast Asia, but in India and in Africa. And as such, what effectively has been a massive funding effort has been put in place. A massive funding effort that probably, as applying the precautionary principle, was reasonable. And that means that the type of investment per case in the region is much, much greater, orders of magnitude greater than what we see in other parts of the world. The positive side of all of this is that we are now seeing substantial declines since 2014, and that most of those countries, probably with the exception of Myanmar, are within 12 to 24 months of potentially fully eliminating falciparum transmission. So let's take it, that's a major success story. However, and to Corinne's point, if we applied that same logic to what we may have at hand in Africa, this would need to mobilize a massive financial effort, way beyond what is being devoted right now. Because what we're seeing now in Rwanda, in Uganda, probably in a number of other places, in Djibouti, in Eritrea, is what was seen in Cambodia in 2007, and therefore the level of alarm that was triggered at that point and the level of investments should be matched to that situation. With the difference, of course, is that the GMS at that time had, by all accounts, what was already a relatively small malaria problem. And now we're talking of the heart of the malaria problem in the world, the heart of the malaria problem in Africa, and our first line treatments potentially being challenged. So it's not a risk that parasites will reach Africa, the parasites are already there. Pedros, is that what we discussed a couple of weeks ago, more or less?
Yeah, thank you very much, Pedro. Thank you very much.
Thank you so much. Before we proceed, I just want to ask my colleague Shayla. Shayla, did you have any questions left here regarding the Horn of Africa?
Yeah, Fredros, perhaps if there's any other experts on the line and they would like to comment, perhaps this would be their chance to do so. If there is anyone who's willing to add on.
So Sheila, this is Rick. Let me just chime in from to give you a sense of some of the discussion on the PMI side. So you're absolutely right to pick on the Horn of Africa, and probably a little known fact, that's where I started my work many years ago in sub-Saharan Africa, and I did it with refugees initially across the border in Sudan, and then with refugees in Somalia from Ethiopia. So I understand a little bit of what's going on vis-a-vis the conflict there, which is an enormous challenge to us as we try to invest in programs. But then we've got an awfully Stephen's eye, and from PMI's perspective, I can let you know that we've just this past week, we had a review internally of our strategy to both on the surveillance side and on the containment side, and what it is we could do, who we needed to be partnering with, and challenging to go across borders because the Stephen's Eye doesn't recognize those borders, but we have challenges in getting to places like Djibouti and along that the reach from Djibouti, where Stephen's Eye has already been documented in Ethiopia and Eritrea, and maybe less so in Somalia, but that's not because it's not there. It has to do more with information systems. So that's a huge issue for Stephen's Eye. And then we've got HRP2 deletions going on at the same time. So, that's about parasites and whether or not they're changed as well as the vector is changed. So this is a huge challenge for us right now. Is there an easy solution? The answer is no. And unfortunately, conflict is going to really make that hard for the near term. That said, we're trying to work with folks locally, support the universities, and to work with folks in Djibouti to set up surveillance systems to track this and to pay attention to the other areas that are at risk of Stephen's Eye moving into them in the peri-urban and urban environments. So huge concern from PMI standpoint, and we're looking at what that means from an investment standpoint going forward. So.
Yeah, thank you so much. I mean, just a side note here, I asked this question earlier to my colleague Noor. Djibouti, Somali, Sudan are not part of WHO Afro. And I mean, we never want to be political in these master classes, but we're just imagining if the numbers from these countries were included in the so-called sub-Saharan Africa, the total percentage burden that is currently 96% would probably be 98, 99. So as you were saying earlier, malaria is really an African problem. And I think that we should not be forgetting these countries. They don't feature a lot, partly because some of them are not in the WHO Afro region. But I think that's a problem that we really must continue to solve. Because of time, we're going to move forward. And we have a very brief question here on severe malaria, and then we will proceed. And any of our experts, you can help us with that. Thank you so much. So we have seen in the report, in the WHO report, this data here, and thanks also to the partners supporting WHO with this. Most of the severe malaria cases really just anemia, and that's quite interesting to see, but also very sad to see. But on the left side, you see a different picture, which is the number of cases being hospitalized seems to be going down. That's true, but the proportion that is severe seems to be either staying stagnant or going up. Is this something? Is there anything that we can read out of this information? And the second question here is, if we tie this to the resistance situation that Corinne was talking about earlier, the artesunate injections that we are currently using, MPAG has put a moratorium on rectal artesunate now. How really will we deal with severe malaria as a secular? What are really the options available to low-income countries here? So any of you can help respond to this, some comments on the severe malaria case, and also how exactly we deal with this, given the limitations on the treatment side of things and the resistance threat.
Noor, I suggest you take the severe malaria ones, and then I can take, if at all, the or Rick on the severe malaria, rectal artesunate suppositories, and some of the management of severe malaria. Noor?
I think there's very little to say in terms of the data itself. The good thing is these are not model estimates, they're just data collected from a number of sites. On the left-hand side, you have data from 21 sites in East Africa. And on the right-hand side, you have data from ANHISA, which essentially shows that while the manifestation of severe disease does change with changing transmission or across different transmission ecologies, you still have a significant burden of severe disease in many of these settings as well, with severe malaria anemia being fairly common. And the other thing you see on the right-hand side is that even as has been hypothesized before, but what it brings to the table is that under declining malaria transmission over many years, you start seeing a gradual shift of the mean age to older children, which brings us back to the topic that was raised earlier on around malaria in older children and severe disease in older children under epidemiological transition. So that's what is the general pattern that's been shown in this data. On interventions, Pedro and Rick, I leave that to you.
On the interventions, I think Fedros, you know this better than I do. I mean, we have very good antimalarial medicines that are highly effective if administered in the right way, in the right dose, at a timely point, can avert a large proportion of all malaria deaths. And we were talking earlier about drug resistance. We have to still say that all our antimalarials continue to work and continue to work very well in Africa in the face of this emerging problem of K13 mutants. So a first message of the drugs that we have are very good. I think you've alluded to the rectal artesian suppositories, which is a pre-referral treatment to be administered on the way to having a full treatment dose, initially parenterally and then completed with a full ACT treatment. And recent results from this Caramel project, which I think are important on a number of grounds. On the one hand, what has often been talked about, the decay in efficacy from effectiveness. So here we have an antimalarial medicine, a suppository when administered adequately, and the patient is quickly referred and the full treatment is achieved, can save lives. So this is not questioning the validity of the antimalarial medicine in this case. However, when you plug it into real life situation, we find out, not surprisingly at times, that the quality of care, the quality of referral, and arriving to the right health facility and being properly treated at the health facility, that does not always happen. And indeed, this Caramel project documented actually an increase in some settings of the case fatality rate following the introduction of rectal artesian suppositories. I think most importantly, what this, highlights is an area that we had not paid sufficient attention, in particular in the malaria world, where we've been far too focused on the commodities. We have paid very little attention to the quality of care, to the quality of the health systems, to not just the referral, but in health facility treatment, and probably unearthing what is a massive problem of quality that often results in monotherapy, and substantial proportion of children probably being treated with parenteral artesunate when it's an uncomplicated malaria and being discharged or sent home and not being followed by a full ACT. So effectively creating the conditions for not generation, but potentially selection of artemisinin resistance or partially resistant parasites. So I think paying greater attention to health systems, paying greater attention to the quality of health systems, paying greater attention to referral. Just having a community health worker is only one step in achieving the impact that one hopes to achieve, and which you won't achieve if you don't have all the different pieces in that cascade of care in place. Rick.
Yeah, thanks for that, Pedro. And maybe to build on it a little bit more, this, apologies for the reference to those who haven't read it, but this is a catch-22. That is, we've got a system in rural areas, remote, where somebody gets severe disease and we have to invoke a system that can get them as prompt a treatment as possible, the referral that's necessary, the continued treatment for the severe disease, and then the full course of treatment in order to clear the infection. And we're asking a lot of people to do a lot of things along the way, because we didn't actually have something that would prevent it out there in the first place. And so the system to try to prevent it in the first place wasn't very strong, and we were asking ourselves to invoke a much stronger system to deal with it. Maybe using these graphics, let me just point out something. So on the left-hand side, we've got 4 circles that are the same size, but if you look at the numbers in those circles, they're not the same size. And the blue areas of the lower 2 ones with the highest parasite prevalence sum to, 3,700 children in that block, whereas it's 140 in the upper 2. So the problem is the disease is in the populations with the highest prevalence, no surprise, and getting the services there for the prevention side of that And this is something that we're trying to pay a great deal of attention on our side in terms of how our support to countries goes. That is, how do we take that community outreach, that peripheral facility, the health workers there, and the community health workers that emanate from that, make sure that they're sufficient in scale, that is, that they saturate the population, that they have the right set of skills, they're supervised, and they're supplied. Because if they're not supplied, we're sort of wasting our time. And then that they're salaried. So calling out the salary, because rather than build a health system, I apologize for using this term, but building it on slavery, that is asking the people who are providing the greatest reach to do it on the side as something that they're not paid for, as something that has not got a career to it, is really a problem. And I'm just suggesting—
You mean community health workers?
Exactly. So if we try to build our health system on the further out we try to reach in order to get to the people at greatest risk, that we use our least trained, least supplied, at smallest scale, then we're going nowhere, and we're going to ask for a system to deal with severe malaria because we couldn't prevent it to begin with. So this is that balance. I'm not wanting to leave that very sick child without the proper care, but I sure would like to have prevented that from happening at the beginning, and make those numbers smaller so that our specialized system doesn't get overwhelmed.
If I may, Fedros, just one word, because I think what Rick has said is so incredibly important, and it's an area that I think, as a malaria community, but it's broader because it's a public health community, we haven't addressed, certainly from our side in WHO, the malaria side, we haven't addressed it sufficiently comprehensively and with sufficient depth. We keep on calling on the need of community health workers. This for as part of the ICCM, or to give out SMC, or now to give out IPTP, but we haven't. We're doing this in a very siloed way, and then in the end, it's countries. Are they going to be paying for these community health workers in a sustainable form? And that's, I think, a big element that we have not addressed, and we will need to address. Otherwise, frustration keeps on building. There's a project that shows this positive impact of community health workers, but then that is not followed up, because the fundamental element is who is going to pay, train, and sustain that effort in the long run.
Pedro, this is Pedro and Rick. I haven't had, I don't know about my colleagues, Nana and Corinne and Shane, I haven't had this perspective before. Essentially what you're saying is the places with the greatest burden, where severe malaria is most likely to happen, are the places where we are sending our least trained personnel to work for free. As Rick says, essentially using slave labor to address the most difficult component of malaria disease. Is that a good summary, Rick?
I think it's fair. I'm obviously using the term slavery as to be provocative, but in the absence of a living wage, you'll actually be training and then training a next cadre, because the sharp ones that you did train initially have left you because they found a job. If we're looking for people to serve in the health system, we actually need to. And so one of the things we've done within the PMI context is that there were some questions whether or not within USAID that we had the, was there the opportunity to actually provide resources to help countries initially in their process of paying community health workers. And the answer is that we've changed that policy such that we can do that. And that's a huge step from our side. It's a small step in terms of what needs to be done, because this is managed by the countries, not by us. We're just trying to become flexible so that we can be supportive of a process. But I'm calling it out because the idea of trying to manage severe disease is hard. You know, if somebody needs a transfusion because they have a hemoglobin of 3 or 4, oh my gosh, where's that coming from? Who's set up to do that? How are they going to get there and survive that process? Respiratory distress, by the time they have a pneumonia on top of that, you know, severe anemia, this doesn't go well. So it's really, really frustrating to be in a position where you know that this was preventable, it was treatable early, you didn't get there. And we have to build that system so that the numbers that we're trying to deal with severe malaria are really small. And we can jump on them, we can focus on them, and we can take care of that. But if you have, you know, if you have thousands of children showing up with severe disease, oh my gosh.
Yeah. No, I wish we had more time to discuss this topic, and maybe it's a subject of a masterclass on its own. We are almost, we have just about 40 minutes to the end of the class. We still have a number of questions we're going to ask our experts. I know you guys are very tired. For the next questions, we keep the answers short. We try and move very quickly. And at this stage, actually, I'm going to hand over back to my colleagues, Corinne and Nana. We had some questions about school children and whether we are neglecting school children, and I think we are. I think we need to do something about that, but we can discuss this later. We had some questions as to why we have malaria in pregnancy appearing to be much more in West Africa than the rest. This is also appearing in the WHO report, but we can skip that for now. Handing this back over to Corinne and Nana. Please take it on from here.
Yeah, thank you very much, Fredos. So we have seen that the reports have shown that they've estimated 627,000 malaria deaths, and there was an increase of 69,000 more deaths. 2/3 were attributed to the service disruption due to COVID-19, and an increase of 14 million more malaria cases in 2020. So we also know, as you can see, in 2020, WHO with partners, they've tried to model and projected many scenarios. You can see that there are 9, looking at the impact of COVID and on malaria, mainly due to disruption. And as Newman, their mosquito net campaign, and then 58% have completed their campaign. But when we look at the data, we are seeing that WHO is comparing the estimated deaths to the worst case scenario, which actually was meant to show that there was no any essential malaria services provided to community. So my question is, why is WHO comparing the estimated death only to the worst case scenario, while there are 9 scenarios that were projected? And then also, is there a possible misinterpretation or conflation of the COVID impact, as well as the change of the new methodology? So I'm sorry that the question will go to Pedro. Thank you.
No. The question goes to Noor. The question goes to Noor.
I'm still here. I have 3 minutes. I have 3 minutes to respond. Can you hear me?
Okay. Thank you, Noor. Yeah, thank you. So I'm sorry, you told me that you are leaving. So I thought that Thank you, Noor. Please. You say Pedro.
So the the answer to your first question, why are we only comparing with the worst case scenario? The worst case scenario wasn't no services, was actually up to 75% reduction in services, both on the prevention side and clinical services. So it wasn't no services, which is still a very high level of reduction anticipated, but wasn't zero services. The reason why we are comparing what we've seen to what we had anticipated or potentially projected under worst case scenario was that at the beginning of the pandemic, when everything was getting locked down, commodity supplies were being disrupted, and things were really, really scary. I mean, things are still scary, but you know, we were really just starting the pandemic. Everyone feared for the worst. And so there was actually a genuine fear that there would be significant disruptions in malaria services. The fact that that did not happen is kudos to the countries and the partners who supported them. So we needed to contrast what we have seen and what we projected. And I think it's important we did that. The second question on whether there's a conflation of the methods and the disruptions, we actually distinguish what would have been the natural increase in deaths, for example, if there were no disruptions during the pandemic. That's why you see the difference between 69 and 47. So if there was no disruption attributable to whatever has happened during the pandemic, you'd have seen an additional 22,000 deaths, in part because the COD method had new and updated data on verbal autopsies from a number of countries, as well as updated covariates, including access to other childhood services, as well as parasite prevalence. So you'd have seen an increase regardless. But the additional 47,000 is what they think is due to disruptions during the pandemic. So there was no conflation. On the case side, the method that essentially in the countries where we saw increases are in those countries where we use the parasite prevalence to incidence model. And there we use the disruptions data directly in the model because there was no change in approach. It was simply a recalibration of the expected population level coverage of intervention and their consequences for parasite prevalence and subsequently for incidence. I'll stop there. I have to leave. Thank you so much, everyone, and good luck with the remainder of your
Noor, before you leave, could you take one last question?
I really must leave, but if it's only a very short question.
Yeah. Corinne, sorry for jumping this, but Noor, this question came from our colleague Yasmin. Yasmin is from Venezuela. This appears to be the Bolivarian Republic of Venezuela appears to be the only place where COVID actually reduced malaria cases.
So, and this is really a critical thing to remember, that depending on what drives malaria transmission, COVID would have had variable impacts on the burden of disease. And so you have a situation like Venezuela, where the upsurge in or the epidemic, malaria epidemic, is related to a number of things, including informal mining and the extent of that mining industry, and then the spillover due to malaria in the mining industry. And because of the lockdowns, a number of things happened. There was a disruption of mobility, which of course you need to get to all these mining areas. There was increase in fuel costs, which affected the extent of mining. But there is an unknown level of cases not being seen at facilities because the services themselves were disrupted, and therefore that influences the reporting rates. We think the majority, as far as our discussions with the regional office is concerned, that perhaps the biggest impact is due to the disruption of the mining industry itself, as well as shortages in fuel. And we will hopefully be unpacking how to attribute this to the different levels of disruptions sometime next year. Thank you. Bye.
Thank you for joining us. Thank you so much. Back to you, Corinne.
I'm okay. That was the only question we had for COVID, the impact of COVID. Thank you.
I can take this one then.
Please.
Yep. So here we can see in the graph the very big dip and the shock that is being affected is being seen by the countries and their real gross domestic product. Plus, we also have the COVID-19, and that's also taken a large toll on the economic activity in sub-Saharan Africa. So my question here really is, and we also mentioned earlier on that the funding from the countries had come to was always flat. So predicting a shock in the economies of these countries affected by malaria, how are we expecting, or how is it expected that endemic countries themselves can contribute to the malaria if we're seeing this crash that is here, knowing also that there's also a good contribution from the countries themselves? I don't know who to give this question to, but
maybe Jen.
I am the worst person to ask a financing related question to. I'm much more of the techie nerd. This may be one for Rick or Pedro to handle better.
Over to Pedro.
Oh, thank you. I was going to say over to Rick. Well, I mean, listen. I guess I'm awful on finances, including my own. But I think it's a no-brainer that economic development, and this was very well reflected in some of the analysis contained in the Strategic Advisory Group on Malaria Eradication. Economic development is a key driver in the fight against malaria, and moving
አሁን ይሄ በአንድ ሁለት የሚያደርጉት አስትሪክስ ነው የሚለውን
Am I the only one hearing some noise there? Yeah, thanks.
Sorry, Pedro, we are going to mute them. Sorry.
No,
yeah, can
thanks.
you continue, please?
No, so just to say, economic development is a key driver in the fight against malaria, and therefore the dip in the GDP that has been observed and not quite got back to where it used to be is a source of major concern. So if this is about highlighting the very close relation between GDP and the progress in the fight against malaria, I think very well noted and cannot be underestimated. We've often praised, rightly so, the elimination of malaria in China and the progress in many other areas. This is also intrinsically linked to the economic development that those countries suffered. And you were talking about Venezuela just a minute ago, and rightly so. Venezuela has been a very painful situation in South America over the last few years, deeply linked to the economic crisis that the country was undergoing. And as my colleagues in the Pajo region often say, the key driver to the malaria situation in some of these countries is the global price of gold. So when the price of gold goes up, illegal mining goes up, and malaria goes up. And when literally, and that's pretty well documented. So an intimate relation.
Thank you, Pedro. Over to you, Frederick.
Nana, I think that was you also. Did you have a question to Jenny, or shall we take that? Hello, Jen, are you still with us?
Yeah.
Sorry, what was the question? Or we moved on to vaccines?
No, yeah. So in my conversation with you earlier, you were saying that there are also a lot of positive effects from COVID, right?
Oh yeah. So I can just keep going on positive effects for ages. Yeah, no, there's been plenty of good ones. So I think Gosh, where should I start? One has been, I was actually just typing this into the chat. One was COVID really brought the global malaria community together in a way that I don't think has been seen for a very long time, to really ensure that we had a solid buffer against service disruption. So it was really heartening to see that when there is an emergency, we can all come together, work effectively across multiple stakeholder organizations to mount a rapid and a very effective response. I think COVID writ large has demonstrated to ministries of health and many disease verticals within those ministries that data matter, high quality real-time data matter, that molecular data is a very informative source of what's happening, how is the situation changing, how is a threat evolving over time. And it also underscored the utility of modeling, mathematical modeling, as an approach for exploring the possibilities of different intervention scenarios. I would hesitate to rely on models for straight up forecasts saying, oh, we expect this many cases to happen, we expect this many deaths to happen, but rather it is a very useful tool for comparing different scenarios. In the case of COVID, comparing the effects of different combinations of interventions, whether it's masks, school closures, travel restrictions, et cetera. And for malaria, we're seeing that same sort of modeling approach. Can we compare different scenarios being a really integral tool in the HBHI process? So I think COVID has really underscored to disease programs and public health decision makers that better, timely information is necessary and can be gathered through a number of different routes. And I see, we've got the slide up here on the screen that's got BioNTech in the background. So I'd be remiss if I didn't talk about how the pandemic, the vaccine effort has really showed the community what it takes to do a large-scale vaccine development well. I'm going to separate that from vaccine rollout because I think everybody on here is acutely aware of the fact that the vaccine hasn't been rolled out equitably worldwide. But if we just focus on the upstream R&D side, we saw that things like a massive investment in de-risking multiple aspects of the vaccine production pipeline meant that you could very quickly get new products authorized under EUAs and then eventually under full approval for use. We also saw the culmination of what has really been decades of work on the mRNA vaccine platform, whether it's the mRNA technology itself or whether it's the way you package that mRNA for delivery. That mRNA vaccines are nothing new in terms of the upstream R&D. That, like I said, there's been decades of work on this, but this was really the culmination of those decades of work and seeing these things roll out for the first time. Lots of excitement. They're performing better than we had ever possibly imagined. So to hear that in addition to other second-generation malaria vaccine candidates, things like CSP nanoparticles, modifications to RTSS, to hear that there's now an mRNA pipeline for malaria vaccines is incredibly exciting, and one that I think, again, because of the success of this particular type of vaccines in the context of COVID, people are going to be watching with much interest. So definitely some good news stories across the board, whether it's data use, community response, or new tools that have been buried in the COVID pandemic.
Thank you so much for that. We should have brought this question much earlier when we were discussing the impacts of COVID more broadly. But you highlight great points here that I think we can take advantage of. You and Pedro and Rick already discussed a little bit about the RTSS vaccine. So here, instead of asking our question again, we just skim through it. But real quickly, one of the things that we noticed from the WHO report is the strong indication that the vaccine should be used alongside other interventions as opposed to being perceived as a standalone intervention. And the other thing that is very clear here, not just from the report, but also from the development pathway, and we are in conversation with Professor Melissa Penny for a masterclass in January. It's really the way the global community and the research community worked around the vaccine. We had so many African research scientists involved, so many different countries, and even when it came to modeling the scenarios, it was a consensus approach. That is something that we also found very, very interesting. It would be nice to hear from you guys. whether such kind of partnerships or consensus is something that we can do much more of in malaria research instead of having siloed groups and so on. So that is one point. The question about cost has come up a lot about the vaccine, where's the money going to come from? And in the beginning, it was about the fears that money is going to be drawn from the vector control. But we have seen the news from 2 days ago, or 2 weeks ago maybe, that the Gavi board has approved now initial funding. I guess it is approximately $155 million or something like that. So this is all really, really good news. And I'm going to hand back to my colleague Nana for one last question on this vaccine scenario before we proceed now.
Yeah, thank you, Pedro. And Pedro, this question will go to you. And it's mainly about the future of the use cases of vaccines in malaria control and elimination. What do you think? Are we looking in the future ahead of us in combining that with SMC, combining our TSS with SMC? Perhaps let's take that one first, and then I can add other ones. Thank you, Pedro.
Yeah. So perhaps a brief introductory note. I mean, I'm building on what Fredros has said. I think this is a great success story of the research and development community that has kept going for 30 years at trying to fully understand the potential of this first generation vaccine for malaria control. And that has actually included probably the largest operational research, implementation research conducted by WHO or supported by WHO in the more than 70 years history of this organization. More than, by now, about 900,000 children having been immunized in 3 African countries, and generating probably the most robust set of evidence for any malaria control tool ever. And certainly, as my colleagues from the immunization department say, of a vaccine. So I think it's a great tribute and to the research centers in Africa that really for 15 years led the clinical development of this vaccine. For the 3 countries that have implemented this MVIP, the Malaria Vaccine Implementation Program, and the evaluation partners that further generated and processed the data that allowed a policy recommendation, a historical policy recommendation from WHO, and now a first window of funding for a malaria vaccine by Gavi. This is important not just for our TSS, it opens up the door for vaccines to play a role in malaria control and for financing mechanisms such as Gavi to support the malaria fight. And as I said, this goes well beyond our TSS. In terms of use cases, I think we're learning on all of this, Nana. The primary recommendation of WHO is for the primary series to be delivered through the EPI scheme. In other words, it's an age-based primary series, which, by the way, is likely to also be the case for the so-called seasonal use of the vaccine, where the primary series will be age-based. Perhaps the major difference will be whether the 4th dose in areas with substantial or very significant seasonality, the 4th dose programs may be given the license to give it just ahead of the main transition season and not through the age-based standard approach. So effectively, there isn't really a big difference between the standard EPI-based, age-based administration of the vaccine and the so-called seasonal administration of the vaccine, because most of the vaccines would actually, even in the so-called seasonal use, would be given on an age-based format. So that's one. Secondly, there's been, and I think you've been right in saying there's been at times a very unhelpful reaction by some of the malaria community, feeling that their preferred tool could be challenged. Oh, is there money for the vaccine going to detract from vector control? And I have found that really quite depressing, to be honest. It seems as if we're worried about our tool rather than malaria control. And this putting one tool versus another, it's really unhelpful, is bad public health. What we need to do, I believe, as a malaria community, when supporting countries, and it's countries that really must lead the charge, is we have an armamentarium, we have a set of tools, and we have to see what is best in a given circumstance. And if best impact is achieved through a combination of bed nets plus SMC or IPTI plus vaccine, that's what we should aim to deploy. It's interesting because this discussion never happened when it was about, say, SMC. It was never thought it's SMC versus bed nets. Never. It was bed nets plus SMC. However, now we're putting this, all this wording, it has to be complementary to other tools. Well, the vaccine works by itself in the absence of other tools. But we want to achieve maximum impact, and that usually will call for the combination of tools. And in some cases, it may call for the combination of vaccines plus SMC or IPTI or other forms of chemo prevention. So my plea here would be to abandon this unhelpful positioning that some groups have taken about protecting their own preferred tool. We are malariologists, we're public health scientists. We have to look at the problem or support the country looking at the problem and seeing what works best for their given settings. It's not about one tool versus another.
Exactly. It's a combination of the tools, depending on the area. And we have another question, Pedro. We've seen, and I've been part of it, and most of us here have also been part of it, that typically for in the RTSS, we saw a very strong partnership between all the different people, African scientists, high levels, different levels. We also found leadership from the WHO. We found all different players working interconnectedly. Whereas typically initiatives tend to be disconnected, and we've seen a nice connected approach from the RTSS. How can we use the benefits of the approaches that we've seen in the success of RTSS to accelerate progress and improve outcomes with other technologies?
So I think that's a great question. RTSS has forced the malaria community to work with the immunization community. And the malaria community, now that we're talking among family, has not been terribly good at doing that in general. And that is one of the reasons why, for example, we're not doing well, say, with IPTP. Why? Because it's a malaria intervention that is delivered by a community, a different community, that is the custodian of that delivery platform. The malaria community feels a lot more comfortable when they control everything. For example, SMC. You have the drug, you hire the field workers, you send them, you don't need to interact with anyone else. But when the malaria community has to interact with others, we really do badly. IPTP is the oldest policy recommendation of WHO from 1997. And we are still at a catastrophic 30% coverage with at least 3 doses of SP, which is a life-saving intervention for mother and newborn. Why? Because it's not the malaria community that controls that, it's the ANC. And we don't like working with them. The same applies to IPTI. It's delivered by the EPI program, not by the malaria program. And therefore, the uptake of that intervention is catastrophic. RTSS, whether we like it or not, forces the malaria community to work with other departments of the ministries of health that are the custodians of those delivery platforms. And therefore, I think an added benefit of the RTSS story is that it will force the malaria community to come out from a mostly siloed space in which they operate to have to work. And if RTSS simply teaches the malaria community that they have to work with others and not just rely on themselves, that probably will be the biggest health impact that RTSS will achieve. So it's a test for all of us. And I think that through the malaria vaccine implementation program, we've learned so much. And countries really did, within the Ministry of Health, the NMCP programs, the immunization programs came to work together. And so the uptake of the vaccine was phenomenal in a very short period of time. The implementability and the acceptability. And that was because they worked together. So in this case, this is a plea from me again. Let's give up our siloed approach, even within the malaria community, because, oh, I'm vector control, oh, I'm chemoprevention, oh, I'm case management. No, we are malaria control. And let's give up our siloed approach in which we are part of a public health response, in which we need to inevitably work with others who are the custodians of the delivery platforms.
Pedro, shall I go over to give it over to you now? Or Corinne, is it?
Yeah. Thanks, Fredros. Thanks, Nana. Yeah, we are not just vector control. We are. That's a good point, Pedro. So we are switching gears to the technical strategies that we have. We can count about 4. We have the GTS, RBM, Global Fund, and now PMI has reduced the strategy. So very briefly, when you look at the GTS, mainly focuses on enhancing access and universal coverage, as well as surveillance. And then RBM sort of looks at, brings in the aspect of ensuring the use or promoting the use of, say, subnational data, as well as encouraging the deployment of new products and new technologies. And then when you move to the Global Fund strategy, it sort of encompasses or includes among the ones that I've mentioned, but focuses on human-centered integrated systems. And then we have the PMI strategy. So then my question to perhaps Pedro and Rick is, how do programs or NMCPs reconcile their national strategic plans with these strategies that we have in place? How would they then use them as guides, given that there are so many of them? What should they be focusing on? Do they really align with the NSPs?
Rick, do you want to go first?
Sure. So thanks for that, Sheila. I would, so on this graphic in front of us right now, my example is fairly straightforward. So, there's a vision. That vision is maybe a couple of different words, but it's no different than what I think the global vision has been expressed by a number of groups. And similarly for goals, the objectives are really about reducing deaths, reducing cases, and supporting countries to move towards pre-elimination where possible. PMI is working in 24 sub-Saharan African countries and in 3 additional countries in the Greater Mekong subregion. But let me focus on Africa because we've talked about that. Those objectives are consistent with all of the objectives in the other sort of global organizations that are trying to be supportive of countries doing their work. And I don't think that they're necessarily contrary in any way. They might be worded slightly differently, but that's in order for us to think about how we can focus the support that we're providing to countries. And then we have 5 focus areas here, and those focus areas, just to call them out, the first 2, reaching the unreached and strengthening community health systems as part and parcel of doing that. That is, getting the services to populations that are not currently being served as they need. And so I'll particularly highlight the idea of reach. This is not about creating access. This is about calling out reach. That is, we have a responsibility in the public health community to make sure that this package of interventions that are proven to be effective get there, not just that somebody can come and find them. And then the third one is about keeping services resilient. It says malaria services, but it's got to be all the services in the public health sector. And that's critical in today's world with COVID, with our next pandemic, et cetera, but also within the pandemic that we're faced with malaria. And then fourth is invest locally. So if we're not doing anything in the midst of this that's right, it's because we're not investing enough locally, and that's calling that out as a special focus area for us. That's country by country. How do we make sure that the support for the science community, the support for program implementation within the country is an investment that's local? And the last one is about innovate and lead. And we've just been talking about the vaccine. That's an example where leading with a partnership at the global level with the immunization programs should set the stage for us being able to support that country by country. So all that is to say is that I think we're trying to align this with country support, country by country. And then finally, there has been extensive discussion, I can tell you, at the global level, with WHO leading some of this, Bill and Melinda Gates Foundation, absolutely in there pitching, and us at the table along with Global Fund saying, how do we move to a single national strategic plan, costed, and the investments from inside the country and the investments from outside the country aligned to do the best possible to support the program? So I think we've talked about this for years. And the question is, can we take major steps forward? Can we use the vaccines introduction as part and parcel of that? And can we use COVID-19 to get us off our duff and make sure that we're really paying attention and not overburdening the country with the Global Fund grant application, with the malaria operations plans, with the National Strategic Plan, with the midterm program reviews, et cetera, that have different people at the table. Let's get the same people at the table, a common plan, costed, that we're all in, that we all help develop so that we can all invest in. I realize that was a long answer, but
Yeah,
I do want to push the notion that this is truly a partnership. None of us have anything contrary to that.
Yeah, thank you. And I see Jennifer nodding vigorously. As you,
and if
like
I may,
me.
if I may,
Yes,
Sheila,
Pedro, go ahead.
No,
yes.
because what Rick has said is so incredibly important.
Yeah.
If I'm allowed a couple of comments. One, it's interesting because these are different strategies from different institutions that may have different roles to play. The Global Fund is a financing institution. The PMI is a technical and financing mechanism and bilateral mechanism. And the GTS is the one that has been developed and endorsed by all member states. But interestingly, there's very significant alignment. There isn't allowing for slight viewpoints or emphasis. They're all pointing in the same direction. So I think that that's an important message to get across. There is no confrontation here at all. There may be even complementarity, and the differences are often explained because of the different roles that each of them has. But this last second point, there should be no mistake. The second point that Rick makes is so incredibly important. You alluded to national strategic plans. Now, national strategic plans, there is a full process which eventually is actually signed by the minister or even at times the prime minister. This is the country's strategy. And they are sovereign countries. And in the process of developing the national strategic plans, all relevant actors within the country and partners have a place at the table. Well, I think is the next key thing that needs to happen, and a really strategic shift is what Rick has just said. We must have national strategic plans developed by the country and owned by the country that are costed. And then the financing partners have to come in and fund those components. This element of concept notes and consultants being flown left, right, and center to help countries write a concept note seems something of 150 years ago. And then committees deciding what they fund or whether the national strategic fund is plan is right or wrong, that we must overcome that. And when we all talk about countries at the center and owning the response, this is a first great example that everybody should commit to follow. We fund what the national strategic plan calls for. And we don't have second or third readings as to whether they've done the right thing or not. So thanks, Rick, for that. We've been discussing this, and I think that is going to be one of the big improvements that needs to happen and change in mindset that needs to happen in the hopefully very near future.
Thank you for the additions, Pedro. I see someone in the chat saying one people, one plan. Back to you,
Indeed.
Pedro.
Indeed, one people, one plan.
Yeah.
I think Shayla, Nana, Corinne, myself, and everybody on the call, we are really, really very lucky that we can be part of this these kinds of conversations. I feel like something great or greater will come out of it, and I'm very, very excited about that. Since we have come to the end, I'm going to read out the few questions that we have left, and I'm going to ask Jennifer to choose one of them or two to answer, and then we will seek the last round of comments from each partner. I know you are all very tired, but we've gone 2.5 hours already, and this has been incredible. We had the remaining questions as follows, and the first, and I will just read them very, very quickly. My colleagues forgive me for doing that. Was the fact that, in the year 2000, we had 241 malaria cases per 1,000 people. In the year 2020, we have exactly the same number, 241 malaria cases per 1,000 people. If you look at the situation in Africa, it's even slightly higher than what we had in the year 2000. Part of this is population improvement. The question we had here is, are we truly making progress, or are we just stamping? And yet the burden is exactly what it was in the year 2000. These are figures from the 2021 World Malaria Report. The second question we had was the issue that Pedro had alluded to earlier about everything being commodities, 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 commodities. Is this really what we must continue doing, or is there going to be a shift at some point where we start looking at more holistic approaches to really change the game? Because clearly we are exactly where we were in the year 2000 if you factor in population growth. So there is a subsection of us who don't want to believe anything about progress. You cannot put the word progress and malaria in the same sentence. If we are talking about 241 per 1,000 in 2000, 241 per 1,000 this year, NMCP directors are having to procure exactly the same amounts and probably at higher cost. Even now you're buying PBOnet instead of an ITN and a different kind of RDT and so on. The third question we had was about high burden, high impact. Since this was impacted, what really is the main indicator of progress since this started? So again, this was just for comment. And the last one was, there's been a lot of talk about China, El Salvador, and several other countries. But if you look at the total burden of malaria in the continent where we live, it's 96%, excluding Sudan, Djibouti, Somalia. If you put those things together, those countries together, Africa probably has 99% of all the malaria. The rest of the countries, there may be 40, 50, 30 countries, all malaria endemic, but in total, they actually constitute only about 1% of everything else. So when we run around celebrating success about country X is now malaria free, country X is now malaria free, what lessons do our African partners learn from this? The situation is very different. And lastly, there was a fantastic document written by our colleague Philip from the Gates Foundation recently, where he, tried to encourage the community to build upon the breakthroughs made around malaria vaccine. We've spoken a lot about this to accelerate the development of other technologies such as next generation vaccines, monoclonal antibodies, ATSPs, and so on. So just very general comments about this. Jenny, you can choose any of these that you want to comment on. And then after that, we will ask each of our speakers and my co-hosts to give their last comment. Thank you. Back to you, Jenny.
Sure, thanks, Pedros. And maybe I'll try and squish a few of them into one very brief answer. I think we are making progress. If you just look at what is in the World Malaria Report, incidence data, mortality data, et cetera, that is a point in time snapshot. It's what's happening now. It's the end readouts of the overall malaria system. But if you look upstream at some of the things that, Philip's calling out in this article, some of these transformative tools, for example, there's a lot of really amazing progress behind the scenes in that upstream space that will one day translate into gains that you see reflected in World Malaria Report data. So I think if we just look at WMR as a needle of where we are in terms of progress, we are sort of discounting a lot of really amazing stuff that is happening in upstream R&D. And as Pedro and Rick just highlighted, in the community coming together around empowering national malaria control programs to truly craft subnationally tailored, data-driven national strategic plans that hopefully in the next year or two, we can start to transition into that single costed operational plan model. So there's a lot of behind the scenes progress that's happening that I am confident will, with sustained and increased attention, will result in tangible, measurable declines that you'll see reflected in World Malaria Report. So there's some good news behind the scenes.
If I may, because I also need to run, and I won't take long. I'm building very much on what Jane has said. Fredros, the fact that we have about the same number of cases or even more now than 20 years ago does not mean that there has not been any progress. There's been massive progress. More than 10 million deaths have been averted and 1.6 billion malaria cases have been averted. So there has been amazing, unprecedented progress. And that has to be reconciled with the fact that we still have a massive malaria challenge, and the two things are actually happening. So this is not the time to simply give up. On the contrary, I think we're building on a history of enormous success, but at the same time, this is not about becoming advocates and we're going to eradicate malaria in the next 20 years, as was being proclaimed not that long ago. No, this is going to be a hard, complex fight. Is this becoming by and large an Africa problem? Yes. Are we doing well? I hope we are doing well. We're calling out the success story. I mean, the webinar we had mostly with Africa on the China certification was China had more cases a few decades ago than DRC has today. In other words, there are pathways to elimination. And even countries that were like China, very poor, and with a massive burden, can get to zero. And I think that that's the key message that we are trying to portray from the elimination effort to the rest of the world, and particularly in Africa. There is a path, and it may be a combination of tools, health systems, economic development. But even if you're in a very high burden area like Nigeria or DRC, you can foresee a future free of malaria. Fourthly, one of the things I've learned about the China certification is that they, many years ago, moved away from a one-size-fits-all approach to a very targeted one. Each district often did different things from the neighboring one, each province. And they had a problem-solving approach. They adopted bed nets, insecticide-treated bed nets, 20 years ahead of anyone else in the world, because they were ready to quickly translate into action. They used chemoprevention massively in different places. In fact, vector control was not the backbone of the elimination effort in China. It was case management and it was chemoprevention. But most importantly, there was a problem-solving mindset, looking at the problem in their specific ecosystem and then trying to address it. And if it didn't work, they would change. And this element of change in the mindset is critical. You know, one of my favorite stories is how much we pushed on the HBHI and subnational tailoring of interventions to countries like Niger that have areas where only 3 rounds of SMC are warranted. Others where 4 rounds were warranted, and others where 5 rounds were warranted. The country wanted to do it that way. And the resistance from partners, and particularly funding partners, to not allow a 5th round in areas where the data clearly showed that lives would be saved if a 5th round was implemented, was truly depressing. We have to push back on that. It is not acceptable behavior. If the country has the data and shows that they would benefit from 5 rounds, who is anyone in this planet to tell them, no, you protect for 4 months, but the 5th month you don't protect? This hampers our progress. We need to break those attitudes, that lack of empowerment to the countries, that lack of evidence-based decision, and only then will we be able to make progress.
Thank you so much. Thank you so much. I don't know about you. I mean, Sheila, I'm going to hand this back to you to do the closing round before guests have to leave. But I'm really overwhelmed by the happiness. I'm grateful. I'm very grateful that we have this opportunity.
So,
Sheila,
so Fredros, maybe just to take one chance at the question about elimination outside of Africa and what does it mean for Africa. Let me just call out that getting those 45 countries that have less than 10,000 cases to have 0 would actually impose the notion that not only can you do this, you can do this just about everywhere. And then the question is within Africa, how to do that. And I just wanted to call out that, right now there's a glass ceiling there to be broken. That is, where is the first sub-Saharan African country to eliminate its malaria? And if we're not thinking that every day, then we're not paying attention to what's the future need to hold. And then where's the second country? And where's the third? So just to put that out there, thanks.
Thank you so much. Thanks. Sheila, please.
Yeah, thank you, Fredros. So a big thank you to our panelists today, Pedro, Noor, Jennifer, and Rick. I think these were very honest discussions, as you can see from the chats, very useful at that. And I think even the overview that we had was really useful, pointing out what the main message of the malaria report is, how the methodology was arrived at, and how we can use this data or how we can interpret this data. All the information was quite useful. Thank you to the participants who joined us today and for the vibrant chats and the comments and the questions in the chat box. And most importantly, a big thank you to our co-hosts today, Nana and Corinne. Unfortunately, Corinne has dropped off. And to you, of course, Fredros, and to everyone. Thank you for joining, and to those who celebrate Christmas, Merry Christmas and a Happy New Year. Back to you, Fred.
Yeah, I mean, I don't want to leave before we have final words from our co-hosts and also our guests. So I don't know who to start with. We could start with Pedro, Nana, Jennifer, Rick, or in any order that you wish.
Well, you mentioned me first. I'm happy to say so.
And by the way, I hope that you guys enjoyed the masterclass as much as we did. So,
well, I enjoyed it a lot. I just want to say thank you all, and thank you, Fredros, and the co-host. You're with these masterclasses, you're paying a huge service to the malaria community. And don't underestimate the value and the impact that these sessions have, and the fact that it's convened by you and the Ifakara Health Institute and the other partners is again a sign of leadership that the continent is taken, that the malariologists, the public health experts from the continent are taken and show the way for the future. So from me, just a big thank you all, and how much I've enjoyed and are grateful for having been with you. Thank you.
And I'll echo that big thanks and that sense of gratitude. I am leaving this conversation full of energy, as I hope many of our participants are. Together, there is a path forward. We can do this.
And perhaps I think it's my turn. Thank you very much to everybody who's participated. Thank you very much, Fredros, and to all the panelists as well. Just wanted to add one more bit. As in everything we do, mainly it's the people who is the center of everything we do. We didn't have much time to talk about the community health workers and MCPs who play a very vital role in the work we do in malaria control and elimination. And I'm sure we'll have another opportunity to talk about that later on. Without much ado, just to say thank you very much, and akwaba, as you say in Ghana. Thank you.
And just to chime in, and huge thanks to those who organized this. I know it's not a trivial process. December's been a very busy month, and to pull this together on short notice was really quite remarkable. And thanks for allowing me to participate. I really enjoyed it. Everybody have a great holiday.
Thank you.
Thank you, everyone.
Thank you.
Fred, you're muted.
I was saying thank you to you, Shayla, and very Merry Christmas to everybody. We see you all next year. We will announce the next masterclass. Hopefully, we're going to have Professor Melissa Penny, and hopefully, we haven't reached out to her yet, but Professor Azra Ghani, perhaps. And we have a few that are already lined up, and we will let you know. So I hope you are able to join us the next time. But thank you, really, thank you so much for joining today. We're closing the masterclass right now. Do enjoy the rest of your days and the rest of 2022. Stay safe from COVID, and regards to families. Back to it. Bye-bye.